So why don't we go ahead and get started. Welcome everyone to the first webinar collaboratively between the Yale Program on Healthcare Environmental Sustainability in the Center for Climate Change and Health, as well as the Nordic Center for Sustainable Healthcare. So a bit of background on the Yale Program in Healthcare Environmental Sustainability. This is a collaborative effort between the Yale Center on Climate Change and Health and Yale New Haven Health Systems Center for Sustainable Healthcare. YFES's mission is to develop and support efforts that measure, mitigate, and adapt to pollution and the changing environment, but uniquely focusing on healthcare delivery. This is an interdisciplinary collaboration between healthcare professionals, sustainability scientists and engineers, bioinformatics scientists, health economists, public policy and legal experts, business management and healthcare administrators, entrepreneurs, and innovators. With that, I'll turn it over to Mr. Daniel Eriksson.
Thank you very much, Jodi, and thank you to Jodi and her colleagues to hosting this webinar series with us. We are very grateful for that. I'm from the Nordic Center for Sustainable Healthcare. We're based in Sweden, but we cover the Nordics and have members from, 15, 16 countries today. We strongly believe that sustainable healthcare is a new industry, a new area for innovation, and a new research field, and that was what we're trying to develop. Today, we have around, we have two different networks that we work with, the one with sustainability, but the one within sustainable healthcare, we have around 115 members from 15, 16 countries. In total, 230 members from many parts of the world within sustainability. And we strongly believe that you need to gather all the stakeholders within sustainable healthcare, not just companies and not just hospitals, but we need to have the universities, the NGOs, the state enterprises together in a network to move this forward. So what do we do? This is three models that show a little bit of an overview of what we do. We believe that sustainable healthcare is interdisciplinary or intersectional. If we're looking at the down left corner, it crosses over many different industries, but not all of the companies and organizations within those different silos, but some of them. So it's interdisciplinary, it's horizontal, not vertical. And in that sense, we mean it's a new industry and a new innovation area. We can also look at this from a research point of view. It's interdisciplinary, it's cross between different departments at the university. What we want to do is also to raise the awareness of sustainable healthcare. We want to boost investment, innovations. We want to bring world-class solutions and ideas to the Nordics, but also deliver Nordic knowledge to the world within sustainable healthcare. It's also important to work with the whole value chain. This is a simplified version, but to start with research, innovation, a good home market, test beds, and then internationalization to get the huge impact that you get from internationalization. The Nordics are very good at this, sustainable healthcare, but the Nordics are too small to make a strong impact. So that's why this internationalization is very important for us. We have produced, for the last 5 years that we've been around with the Nordic Center, we have produced a lot of reports and knowledge in different ways. Mostly non-scientific, but we're hoping to get more scientific reports and articles in the future. So I invite you to check out our webpage for this information and more information on what we do and so on. And here's my contact information if anyone wants to ask something or share something. Thank you very much.
Thank you, Daniel. Just to give a bit of background to this session today, why sustainability in healthcare? Pollution is a leading cause of morbidity and mortality. 9 million premature deaths annually, or 16% overall, stem from pollution. Healthcare is 10% of the global economy, 3.6 trillion in the US, or nearly 18% of our global domestic or GDP. And hospitals are 2.5 times energy intensity of equal sized commercial buildings. They run 24/7 high-tech diagnostic therapeutic equipments. Unlike other industries, we have very unique responsibilities around infection prevention because of both the risks and the regulations. We do have a lot of regulatory complexity and business models that are driving wasteful, unnecessary utilization of resources, which is a big problem in the developed countries, especially in the US. And in the rich nations, we have a culture of excess and disposability that is normalized. We have a lot of lessons to learn from developing countries there. Overall, healthcare is a leading emitter of environmental pollutants that adversely affect human health. And in terms of the supply chain risks, both pandemics and climate change have a lot of similarities in terms of risks and also solutions, which is why we're having this session today. Now, the COVID-19 global situation, unfortunately, is worsening. This data is from today, from both the World Health Organization and also European CDC. Over 50 million confirmed cases, and that's where we have capacity to testing. And we are particularly concerned in this abrupt rate and rise that we're seeing now as the cold is hitting us in the Northern Hemisphere. Globally, healthcare is responsible for 4.6% of total global greenhouse gas emissions. Now, we're not just worried about greenhouse gas emissions, but it is the one that is on top of everyone's mind. It's also closely related to air emissions because air pollutants, because they both stem from burning of fossil fuels. And the US is an outlier here with the highest per capita greenhouse gas emissions per spend. We also spend twice as much per capita on healthcare as any other nation. We don't have the best outcomes. We're among the best, but we don't have the best outcomes. So we have a lot of room to improve here. And globally, the trends are not promising in terms of healthcare emissions. So we have to make a difference. The Intergovernmental Panel on Climate Change special report on global warming that came out in 2018 was pretty stark. Over the remainder of the century, if our emissions remain uncurbed or business as usual, we can expect conservatively between 4 and 5 degrees centigrade rise in average surface temperature. The current policies bring us closer to 3 to 3.7 degrees rise. Pledges for the Paris Accord, 2.6 to 3.2. So it doesn't even get us to the aspiration of 2 degrees centigrade. And really, our global scientists are telling me we need to aim to 1.5 degrees average warming. We've already achieved 1 degree warming. And basically, the carbon accounting tells us that our anthropogenic CO2 emissions need to fall by 45% by 2030 on average. The bulk of that has to come from the developed nations who are contributing the most. And we need to reach net zero by 2050 in order to achieve this limit of 1.5 degrees rise by the end of the century, to avert the worst predicted impacts to public health and our civilization. This is possible. We can do it. It's a matter of political will. And so in terms of healthcare's relative emissions, this is the work coming out of other global leaders besides the Nordic Center. This is from the National Health Service in England, which shows where the relative emissions are coming from. And importantly, 2/3 of healthcare's emissions are coming from the supply chain, medicines, chemicals, consumable equipment and medical devices, as well as capital equipment and other aspects of the supply chain. There are numerous studies that show 60 to 80% of healthcare's greenhouse gas emissions stem from the supply chain. Healthcare administrators and clinicians, we control which supplies we use and how many. Manufacturers and regulators control embedded emissions and what goes to marketplace in terms of where our leverage points are to help solve this solution. Again, we turn to the NHS, and we'll be hearing more from our Swedish partners today. The NHS has committed to achieve net zero, and not only have they committed to it, but they have projections. They understand where the emissions are and plans of attack and how to tackle those. Similar efforts are required globally to measure and understand how to implement and tackle this problem. This requires carbon accounting standards and industry transparency and reporting standards. And as we've seen, the flattening curve image here, this applies both to COVID and climate change. The idea is we can't make the pandemic go away, but with protective measures, including social distancing, masks, hand hand washing being the most important measures. The idea is to slow down the progression so that we can stay within the healthcare system's capacity to respond. The same is true for climate change, that just substitute the Earth system's capacity to respond with protective measures. The difference between COVID and climate change is that we have about 10 years to solve this problem, and many of the solutions are very similar. So there's a lot of analogies here. So there's opportunity for economic growth and a green recovery, so we don't have to suffer the consequences of economic shutdown with the pandemic. So today's speakers and topics, I'm pleased to introduce Professor Benn Carson, who's Associate Professor of Operations Management from the Judge Business School, University of Cambridge. He'll be speaking on design and management of a resilient supply chain. Dr. Patrick Kenney, who's Associate Professor of Urology from the Yale School of Medicine. He's also Medical Director of Corporate Supply Chain for Yale New Haven Health System, and the founder and chair of Supply Chain Physician Collaboration, which is a large integrated delivery network. And he'll be speaking to COVID-19 physicians and supplies. Inability to supply PPE is not the true supply chain crisis. Dr. Rosemary Kumwenda from the United Nations Development Program, Sustainable Procurement and Healthcare Coordinator, will be speaking on lessons from sustainable procurement in the health sector, challenges and opportunities. Mr. Adam Robinson, who's former chairperson of the Association of Medical Device Reprocessors and regional director for HoverTech International, will be speaking to the reprocessing industry and the impact of COVID-19 on the reverse supply chain. Mr. Andreas Hagnell, forgive me for pronunciation, you'll please correct me, is senior advisor for Environment and Energy Department for Growth and Community Development from the Swedish Association of Local Authorities and Regions. He'll be speaking to carbon disclosure in Swedish healthcare, how to include the scope 3 emissions, which is a big challenge. And Professor Ornella Benedettini, forgive me again for pronunciation, who is visiting research fellow from the Judge Business School, University of Cambridge, who will be speaking to the servitization business model from products to use-oriented services. For moderators, you have myself and Mr. Daniel Eriksson, who you've already met, as well as Mr. Joe Bialwich, who's currently the Director of Sustainability Solutions for ING-IND. The logistics from the sessions today, importantly, everyone should know the session will be recorded. The audience may ask questions via chat only, and everyone, not just speakers, we encourage everyone to respond in the chat because there's a wealth of information you all have, and we need to support each other in this rapid transition. Depending on the timing, there will be 1 to 3 verbal questions synthesized by the moderators between speakers, with the exception of Dr. Kumwenda, who's very ahead in time zone. And so we will be taking all her questions after her session. For the remainder of the panel, there will be questions at the end, time allowing. Without further ado, I turn it over to our first speaker, Professor Carson.
Thank you, Jodi, for the kind introduction. And it's a pleasure to have the opportunity to speak today. Supply chains are no stranger to managing disruptions. Indeed, dealing with disruptions like natural disasters, supplier failures, these all fall under firm standard risk mitigation practices. So the question then is what makes COVID-19 so different from a supply chain resilience perspective? Many of the firm's activities in this space have been around thinking about how we segment risk. So how we, typically on the basis of probability versus severity. So we might think in the bottom left-hand corner, low probability, low effect events. These are our daily headaches. Or the top left is firefighting. These are the manageable surprises, don't happen very often, but they're part of contingency planning. The top right-hand box is what we could think of as gray rhinos, the obvious threats to business continuity. So these are such as a pandemic was on many firms' planning register and contingency register. Of course, not in the globally correlated way that COVID has transpired. And then in the bottom right-hand corner, we can segment risk based on black swan events, so major events that have a low probability of occurring. And this figure actually is from some data from General Motors, and it shows that over a 1-year time frame, all of these events occurred within their supply chain. So, disruptions are continuing. The thing that is different here, though, is that the risks we see for GM and for most firms is the disruption remains local or regional, and it's contained to the supply side. So in that sense, COVID is unprecedented. We have a global event affecting demand and supply side, entire regions being affected in waves, freezing workforces, materials, transportation routes. So even those firms who had pandemic in their contingency planning probably hadn't planned for such a severity. And it's easy to understand why supply chains have turned out to be so fragile in the face of the pandemic. And here's just three very simple examples. We have a tennis ball from Wimbledon. So hard to think of a more simple product, but it travels over 50,000 miles across 11 countries and 4 continents, with most of the production centered, if you can see the map, in Malaysia before it makes its way to the UK. Or a more contemporary example, a Medtronic ventilator has over 1,500 parts from over 100 suppliers across 14 countries. And these are individual products. Once we start to think about supply chains for firms as a whole, then the picture, of course, gets even more opaque. So the very last figure is Toyota's supply chain. And this shows actually, whilst you probably can't see it, but the various tiers of Toyota's supply chain with each node represented by a dot and the linkages between them. So it's little surprise that when the pandemic struck, that firms are facing challenges around their lack of visibility. And indeed, many seemingly relearning lessons from even Fukushima nearly 10 years ago around the damage and difficulties when supply chains are disrupted in the lower tiers. For a healthcare setting, I just wanted to raise, I guess, 2 examples. One that we have experienced and continue to experience, and the other around what might happen, and maybe just raise a few ideas on that front. So the most high profile example of supply failure so far across virtually every country has been the provision of PPE. And the left-hand figure is an article or data from an article out of the Wall Street Journal looking at the gap in domestic provision of N95 masks in the US. And it tells an interesting story that every firm if we think of this as a simple supply chain, as the government, the hospitals, and the manufacturers of N95 masks, each firm had maximized its own activities, but in doing so, collectively, we have disaster. So hospitals had moved to just-in-time inventory. Firms themselves, in the wake of SARS epidemic in 2009, they had pared back excess capacity domestically so that when the pandemic struck, there was very little in the way of surge capacity that could be responsive to the demand spike. And the US government probably focused on other priorities rather than pandemic planning. But the key point here is that every party had prioritized efficiency over resilience. And this is probably a microcosm of how many companies have been trading off efficiency versus resilience over many years. The second example, I think, is the COVID-19 vaccine production and potential bottlenecks. So we had the exciting news from Pfizer yesterday, so I thought I would update the slides to reflect that. In the pandemic in March, we had bottlenecks pop up in unexpected places, like empty pasta shelves. And it wasn't that there was a shortage of pasta in the system. There was plenty of pasta. Actually, one of the bottlenecks there was packaging, that the packaging suppliers for the small retail-sized packets of pasta just couldn't keep up. And I think it's interesting to reflect on what might be potential bottlenecks if we're thinking about the vaccine distribution. So there's the obvious challenge of transporting, at least what I read was 800,000 tons of vaccine. But then we've got other critical potential bottlenecks. So fill finishing, stoppers, lipids, syringes, brewing equipment, cold chain logistics capacity on a scale the world has never seen before, glass vials that I'll come back to, and I think on a sustainability front and safety is not to mention the collection and disposal of syringes. You know, we're probably going to have what, 12 to 15 billion vaccine shots over the next handful of years. All these things are occurring on a scale that's never happened before. And I think the key point is that for many of these components and items, the supply chains are set up for relatively stable operation. So glass vials, you know, fairly steady requirements, around 6 billion vials a year for other critical vaccines like typhoid, flu, meningitis. But we're looking at 12 to 15 billion vaccine shots. So the challenge here in the supply chain is we only have a handful of suppliers that can supply at scale. So Corning, Thermo Fisher Scientific and Schott in Germany. And we're already seeing shortages. So there was a professor from Oxford hosted on the BBC about 2 weeks ago, said, look, there's 200 million vials available in the world right now. And a lot of the capacity is being stockpiled by others in anticipation of a vaccine. So if we take a European perspective, asking for 1 billion vials, you're waiting months, if not, you know, a year or two. So I think it'll be interesting to see how that unfolds and where unexpected bottlenecks will pop up in dealing with the vaccine. In thinking about a typical disruption, so typically we see vaccines operate in a typical path. So a very simple setup, we see the blue line is the pathway of a potential disruption. So initially we're in preparation mode, the disruption occurs, the initial impacts may be slight as, say, inventory or capacity is drawn down, and then eventually the full effect of the disruption occurs, and eventually we start to recover to normal. So it's useful here, I think, to define what we mean by resilience. And typically resilience has two elements. So one is robustness and the other is the recovery. So robustness in the sense of how long can we continue normal operations before suffering costly disruption? And then recovery, once we've had the impact, how quickly can we resume normal operations? And you can think of resilience as a composite of those two ideas. Can we maintain operations? And then how quickly can we recover? And I think the key part of resilience is how we have to shift away from thinking about how do we respond to a specific disruption risk. So scenario planning is I guess, a normal way of doing that. And towards thinking about how do we develop a capability in our organizations to respond to whatever the risk events might be. And in the yellow text, I've just sort of paraphrased what you might think of the generic phases for the COVID pandemic of preparation, protect and surviving that we certainly saw over the March to June period, and hopefully now starting in many industries to be in a recovery phase. And ultimately, we're going to then be reconsidering what changes we need to make to operations and supply chain. What can we learn? What are some of the key pillars of an effective response? I think one of the key lessons that we see is that the effect of a disruption is not preordained. The decisions that are made by managers and those responsible for designing and managing supply chains greatly influence how the same event affects different firms. And three levers that we might think about here are culture, flexibility, and visibility. And I'll just tell you some quick stories on each. So culture, the classic example in a supply chain sense is the battle between Nokia and Eriksson in the early 2000s. They were locked in a fierce battle in the mobile phone market. Both were sourcing microchips, sole sourcing microchips from a Philips plant in New Mexico. One Friday night, lightning struck the plant, caused a fire in the clean room, which contaminated millions of chips. And then you saw how each company reacted differently. Nokia's attitude to risk and their processes saw them quickly escalate the event, had people on site within 24 hours. They were able to switch suppliers quickly, re-engineer their phones to accept different chips, and were relatively unaffected. Eriksson, by contrast, accepted Philips's word that production would be back on track and took no action. And it was by the time they realized it was too late. That decision cost Eriksson more than 400 million in earnings and lost market share. By contrast, Nokia's profits rose by 42% that year. Flexibility matters. So we see during the pandemic with COVID-19 overwhelming health systems in Europe and the US, a number of luxury good manufacturers stepped in and were able to switch operations to make urgently needed items. So LMVH's perfume factories made hand sanitizer, Armani, Gucci, Prada revamped designer clothing factories to make medical overalls. And here in the UK, Burberry moved a trench coat plant to make face masks and non-surgical gowns. So this wasn't just about rapid retooling. This was about flexibility in their supply chains and operations where previous investments in rapid raw material sourcing, product design, distribution paid off. And I think that's another lesson here, is that we don't value flexibility nearly enough, yet that's what's underpinned many of the effective responses to COVID. My last pillar there around visibility. So many of you may have heard of the concept of a supply chain control tower. Essentially an idea where we can get real-time information on production and external demand, inventory and supplier status. And that's helped P&G and Walmart have established processes here for dealing with things like hurricanes, to reposition suppliers, plants, distribution centers to minimize damage. Or Toyota is able to visualize their supply networks for each component, and then if disaster strikes, they're able to know which parts are at risk and take action. And I realize I'm almost out of time. I wanted to just finish with one slide just to flag some of the potential ideas that perhaps we can discuss later around what we might see in the supply chain and what we might see in healthcare providers. So there's certainly a lot of talk around supplier diversification, new suppliers, new geographies, bringing production back home. And if you look in the US, at least, Joe Biden's plans for manufacturing, there's a lot in there around healthcare, onshoring, building new domestic capacity, holding strategic inventories of critical PPEs. So I think it'll be interesting for many medical products that have traditionally not had this level of oversight and intervention on how things change. I suspect many of the other dot points are fairly self-explanatory, Jodi. I think I'm nearly out of time. Other than I think I would point to, on the provider side, the collaboration. And perhaps other speakers will touch on this as well, but we need to see collaboration across multiple pairings in the supply chain to try and minimize these effects of future disruptions. So I don't want to take everyone else's time, so I'll perhaps leave it there and look forward to questions.
Yeah, Ben, thank you very much for the wonderful overview. If we could just maybe ask you to elaborate a little more on this fundamental tension that you identified between efficiency and resilience. You said that we had prioritized efficiency much more in global supply chains over resilience.
Yeah, so it's an interesting one. I think what we've seen in supply chains across most industries, right, is, and including healthcare, we have cost pressure. We have procurement that is incentivized or at least judged by their ability to manage costs, and that sets up a natural tendency that we look for lower cost sources of supply, and we therefore end up with long lead times, unresponsive supply chains. And you know, we've benefited from that in terms of having cost reduction over a period of probably the last decade or two. So how will things change? I think partly we need to reflect on what we conceptualize as value. You know, efficiency is about cost. If we think about value, then we need to be incorporating other things like resilience, like the value of flexibility. But we also, I think, need to be willing to pay more. You know, that we've in some ways artificially benefited from not having to deal with the externalities up until now of a long lead time supply chain. So I think that'll be one of the challenges, for example, Joe Biden's plan of what does it mean to onshore? And if you only bring back a responsive last stage assembler, what about all the other suppliers who may still be based in China and you still have the same hidden risk exposures? So to your question, you know, I think we need to have a more blended view of efficiency and resilience, and they're not necessarily trade-offs. That some of the examples I had in the last slide of shifting warehousing closer to customers, or perhaps diversifying the supply base. These may not necessarily cost you more money, but will improve resilience.
Wonderful. Thank you, Ben.
Thank you.
Hi, Ben. Thank you very much. Just a little bit of a reflection on the Eriksson case. I myself is a very unhappy shareholder for 25 years at Eriksson. Actually showed plus now for the first time in 25 years. Yes. So, yeah. But the thing you might think as being naive in those, if you're looking at the Eriksson's case, is actually something is discussed a lot in the Nordics. The Nordic trust is one of the keystones or strongholds in the Nordics that has actually made the Nordics develop very positive in many ways. It's the Nordic gold, they call it trust. We believe someone, if they say they're going to fix that, we believe that. So it could be an advantage sometimes, but sometimes a disadvantage, surely. Yeah, but it's been written reports on that, the Nordic trust.
I certainly look at that. Very quickly, I would say, I think was it Henry Kissinger who said, trust but verify? Yeah. And yeah, absolutely. And that's the challenge, is the verification piece as well. Yeah. Yeah, but I agree, trust is super important to greasing the wheels of supply chain relationships.
Thank you so much, Ben. Without further ado, we'll move on to Dr. Pat Kenney.
All right, everyone. So my name is Pat Kenney. I am a urologist. And up until very recently, I was the medical director of supply chain for Yale New Haven Health. I've transitioned out of that role to take on to be the interim chair of urology for Yale. I'm also the medical director. I'm also the founder and chair of a group of physicians we're called the very simple name, Supply Chain Physician Collaboration. It's a collaboration of physician leaders from 25 of the largest healthcare systems across the United States, which proved to be a very helpful collaboration for us during COVID. I don't have any relevant disclosures. An overview of my talk today, I wanted to talk a bit about supply chain risks from the hospital perspective and mention some the levers that we can employ to impact resiliency. I also wanted to briefly go over Yale's approach to PPE with respect to COVID. And I want to make end really with a very brief argument that there is a narrative out there that COVID broke the health system supply chain. And I don't think that's actually accurate. I think it exposed a supply chain that has foundational problems, as mentioned by our first speaker. So the COVID PPE crisis really comes from this very substantial volume of patients that came in with COVID, but it also impacted non-COVID care, right? And some of these changes are going to be durable. The amount of PPE that we're using for non-COVID patients is far different now than it was 6 months ago. It's led to changes in the way we provide care. We're not providing certain care as our COVID numbers start to go up again. But really fundamentally, COVID led to a very substantial increase in PPE use, both for COVID patients and for non-COVID patients. And this exposed supply chain instability. And the summary from my standpoint of that is demand far outstripping the supply of disposables. manufacturing capacity that could not possibly increase to account for increased demand. When we talk about resiliency, when we talk about the value of resiliency, I think we need to think beyond just manufacturing capacity, because it will not be possible to actually pay to have the manufacturing capacity necessary to account for a pandemic like COVID. Distribution inefficiency has already been mentioned. Competition and sourcing. So there was rational competition and sourcing out there in the marketplace, and also irrational sourcing. So fear-based sourcing. So people afraid of what's to come and buying an irrational amount of product. We also saw in the United States very clearly the government, the federal government, acting as a competitor in the marketplace, so buying vast sums of PPE, and then at the same time that we were looking to use it for providing care, it was getting put in stockpile. So stockpiling during the crisis itself. We also experienced pipeline uncertainty, and so what I would say are we consider our pipeline to be the products that we have come to agreement to purchase. And so meaning there's a vendor selling N95 respirators. We might come to an agreement to purchase 500,000 of them. We've come to terms, may or may not have exchanged payment yet. And then those devices never actually show up. So uncertainty once it hits our pipeline. And then we also experienced obviously importing risk, political risk, things like large orders coming from China not being allowed to leave their shores by the Chinese government. Supply chain risks, I think of as broad categories: manufacturing, sourcing, logistics, distribution, financial, geopolitical risks. We've seen it in the US with Hurricane Maria, for instance, that impacted Puerto Rico and decimated Puerto Rican healthcare supply chain. So we get a lot of pharmaceuticals from Puerto Rico, a lot of devices from Puerto Rico. And just by having it concentrated on one island, we had significant supply chain risk. The levers we have to improve resiliency on the hospital side, thinking about our geographic diversity. So not just a globalized supply chain, but perhaps doing things locally as well. Can't do everything locally because we're at the same risk then. If an event hits just Connecticut, where we're located, then our supply chain is also at risk. Moving towards reusables to avoid short-term supply chain instability. And to focus on fewer transactions with higher reliability, developing direct relationships with manufacturers, eliminating middlemen, simplifying the supply chain, and then moving towards stockpiling. So critical supplies on stockpile were one of the fundamental ways we were successful in the first surge in the spring and summer. So what has Yale accomplished so far? So we have treated in our healthcare system and discharged about 4,400 COVID patients. We've had a very low healthcare worker infection rate. We tested about 14,000 workers, and our infection rate was about 0.2%. We did not have a single stock out. Stock out meaning that we ran out of a particular device. We certainly had distribution problems within our own system, but we never ran out of a particular amount of a particular type of PPE. We resumed normal operations as the initial curve of patients went down, and I would argue that we have improved resiliency for the second wave, which does seem to be in progress. Something I'm pointing out with the arrow there is, as of yesterday, we had 191 patients in our system. We have more than 200 now, COVID patients across our healthcare system. This has increased quite dramatically over the past few weeks. And you'll notice that the white line on top, that's our non-COVID patients in our healthcare system. We still have a large number of non-COVID patients in our system, which we did not have in the spring. So we are trying something new, which is to continue normal operations during an outbreak. We learned early on that you cannot possibly procure your way out. And I think this is actually a really important thing from a sustainability standpoint. The typical response from a hospital supply chain to a physician request for a product, to a nurse's request for a product, to a new patient care endeavor is to go out and purchase a device. We learned that that's not going to be possible for COVID. We simply can't go out and just buy stuff. Why? Because the market didn't have it. So what did we do? We borrowed from the recycling world. So the idea of reduce, reuse, and then instead of recycle, we called it reprocess. And so for reduce, what do we mean by that? Decrease utilization. We clustered care. We moved sensors and controls to the halls. We did what's called cross-utilization. So rather than have multiple people enter a patient's room, we reduced it down to one. For instance, our nurses were doing some of the work typically done by the janitorial services. We used teleconsults to have Instead of having a cardiologist go in to see a patient physically, we had them do the consults electronically, so they would not be using PPE. We also engaged in what's called limited reuse. Previously, respirators, FFRs, or N95s, were used just once per patient interaction. So you would don it, meaning put it on, interact with the patient, doff it, and throw it away. Limited reuse is a strategy where you use one respirator per shift. So you put it on, see a patient, take it off, save it, then reuse it again. The concern about that is the possibility of the respirator perhaps infecting the person who's wearing it, becoming a fomite. But what was so important was that this decoupled utilization from the logarithmic growth in patient volume. So we linked respirators to the number of respirators we used to the number of people working and not to the number of patients they were caring for. And so these two processes of reducing and reusing led to a more than 90% reduction in respirator consumption on a per patient basis at our health system. So an airborne precautions patient at Yale prior to COVID, we would use between 50 and 80 N95 respirators per patient per day. When we had at our peak more than 800 patients on our healthcare system, we would be using 40, 50, 60,000 per day. Instead, we were using 5,000 per day. So a dramatic decrease. Nonetheless, that was still a 30-fold increase over what we typically use. We usually use in our system 5,000 per month. So we also moved towards reprocessing, and the idea, we reprocessed almost everything we could: respirators, masks, face shields, gowns, elastomeric respirators. We have a purpose-built facility that we built in 4 days for vaporized hydrogen peroxide. We also used external vendors, even with things that are not environmentally friendly. So not all reprocessing is sustainable or good. We used ethylene oxide, obviously some serious concerns there. And there are other real limitations. So we have a very high discard rate. We evaluate each respirator that we receive for reprocessing, and fewer than half are actually capable of being reprocessed, either because they're stained, they're broken. We also know that wear impacts fit. So the more times you reprocess it, the less likely it is to fit. We also know, and we have a paper that's being reviewed now for publication, that filtration may be impacted. So at Yale, we only reprocess at most 3 times. There are other groups that are reprocessing up to 20 times, something which we have not adopted and which I think is a mistake. This is the facility, the building there is what's called a regional operations center. It's one of our warehouses. We built a dedicated facility that's capable of reprocessing 250,000 respirators per week if we were running it 24/7. Obviously, we have not needed those numbers yet. We also adopted the use of elastomeric respirators. This is a reusable respirator, non-disposable, that we then reprocess after it's used. We have more than 10,000 in our system, and it's helped reduce our reliance on the disposable marketplace. This was highlighted in the New York Times. One of our intensivist care physicians, Dr. Elaine Fajardo, said, "I think these really saved us from a crisis." And I agree with her. This is something we started working on in January. The backbone of our response really was what I'm referring to as a clinically integrated supply chain. And I would argue, as we think about sustainability, we need to integrate sustainability into our supply chain using similar techniques. We have clinicians embedded in supply chain, myself as a medical director, nurses as well, interdisciplinary partnerships with a variety of people who are involved in decisions around PPE, and then forging very strong collaborations with respect to knowledge, data, and leadership. Communication was a very, very important task to focus on. We had frequent policy changes, supply changes, and then we needed to prepare our workforce for all of the changes that they were seeing. We used dashboards, websites, video town halls over Zoom. We used videos for donning and doffing. We created a liaison program. We even did radio, TV, and print interviews, getting the word out to our staff. Transparency of supply, transparency of impact, very important, and I think is also relevant for the idea of sustainability. Any one of our employees is able to see at any time the number of days on hand we have of PPE in our health system, and our current burn rate, and with a very intuitive analytic. Are we red, yellow, green? Green meaning that we have a healthy supply. We are working on demand forecasting. That is much harder than you think, because it is the amount of uncertainty with respect to the predictions of what our demand will be are very difficult. And we do our best to try to predict stock out, meaning running out of supplies. Collaboration cannot be, the importance of collaboration really can't be overemphasized. We collaborated with our community in terms of donations of PPE. We worked with the various resources in our university. Our virology lab was able to help us demonstrate that vaporized hydrogen peroxide was virucidal, the first demonstration of that that happened. We partnered with clinicians. We had external partnerships with the United States Military's Defense Logistic Agency, the World Bank, and various Vizient forums, sharing knowledge, sharing expertise, learning from others. Importantly, this is an iterative process. So the PDSA cycles, the idea is plan, do, study, act. Plan an intervention, implement the intervention. Did it work or not? And then change it. My argument here really, though, is that COVID is a supply chain stress test. For those of you who are not clinicians, a stress test is the idea. If you suspect someone has heart disease, you put them on, you make them do exercise. You dramatically increase oxygen demand, and you see what happens. Do they get chest pain? Do they have EKG changes? COVID is the same thing. We dramatically increased the demand and exposed structural defects. These are the foundational problems, in my opinion. One, in healthcare, there's a very significant inability to determine value. There's very little price transparency. Price discovery itself is quite inefficient. There's poor or uncertain quality. And I'm determining or defining value simply as a function of quality and price or cost. And poor or uncertain quality in PPE meant counterfeit items, items that did not meet typical standards that are accepted internationally, items that we bought in the marketplace or procured that we then sent for independent testing and they failed. Worsening value, not just poor value, but where we saw dramatic increases in price, 40, 50 times what we typically pay for an item, at the same time that quality for that item goes down. So we don't expect a functioning marketplace to do that, right? A functioning marketplace, higher price theoretically, or higher price paid should correlate to better quality. That did not work. Back orders, transactional failure, and then a real lack of evidence to guide clinical decision-making. Is there a role for universal masking? When is an N95 required? Is fit testing important? I would argue that value really is elusive. We know it's a function of quality and cost of care. But I want to know, really, why is improving supply value so difficult? This applies not just to PPE, but to healthcare supply chain in general. I'm using physicians as really a decision maker about what supplies we use. Physicians don't know the prices paid for supplies, let alone more comprehensive costs such as environmental impact. There is not selection pressure for cost at the level of the physician. In the United States, physicians make a lot of decisions about what supplies we use. And there's various reasons for this, which we can't really go through today, which is prices vary over time. There's rebates, there's non-disclosure costs. There's a system built, a confusopoly, it's called, a system built to make physicians not know. Quality is very hard to define. The data are problematic. There's a reproducibility crisis in the healthcare literature, a very weak regulatory environment in the United States. Even the best research is wrong. We know this. And this leaves room for influences on physician preference other than cost or quality. In the United States, industry paid more than $10 billion in 2019 to physicians. What did they get for it? They get preference, they get prescribing changes. In the United States, as Dr. Sherman already mentioned, healthcare spend approaches approximately 20% of GDP, with private sector spending being threefold that of other countries. The value that we're getting for that is uncertain. The market does not seem to be selecting high value care, but we know that greatness can be achieved despite austerity. And this is something that I think we need to focus on. This is a picture of Leonid Rogozov. He was a surgeon from Russia in Antarctica in 1961. 2 weeks after his arrival on an Antarctic base camp, he diagnosed himself, without imaging, with appendicitis. He was the only surgeon there. He was the only physician there. Without anesthesia, he performed his own appendectomy. He described it, or his son described it in the British Medical Journal about 10 years ago. 2 weeks later, Dr. Rogozov was back at work. If we assessed the impact of a very expensive, modern appendectomy, laparoscopic appendectomy, expensive antibiotics, expensive devices. And we said that the person who suffered that appendicitis was back at work 2 weeks later. We would view it as a great success of modern healthcare. This was 1961 in the Antarctic, and he did it by himself. Greatness can be achieved despite austerity. We need to think about what value means, and we need to think about the impact of the decisions we're making around device supplies. So healthcare supply chain truly was in crisis before COVID. COVID was just the stress test that exposed it. I would argue that we've learned that clinically integrated supply chains are very helpful. We need to educate providers about costs. Supply chain must help stakeholders assess value. We've got to align our interests. We need to focus on resiliency. All of these lessons are lessons that are relevant for sustainability. And I think a challenging question that I'll leave the group with is, if our system does not consider effectively dollar costs and quality, how are we going to ensure that it considers environmental impact and sustainability? It's a very challenging problem. I think your task in front of you is substantial, but if we address the concerns of cost, of value, I think we can ensure we address the concerns of sustainability.
Wow, thank you, Dr. Kenney, for an outstanding talk and for all you've done to help keep our health system safe. As a clinician, I'm very grateful for the work that you've done. I think we have time for one question at this point, possibly more at the end from the audience. And synthesizing, I'd like to ask you, in your opinion, what are barriers to, there are actually several studies, ethylene oxide aside, several studies that show that reusables have a lower environmental impact and in many cases are cheaper than disposable devices. Now that's not true across the board, and many things cannot, it's just not feasible to clean. And obviously in times of crisis, we need to do whatever we can, including ethylene oxide. But in your opinion, what are some barriers to reusing devices?
I mean, I think it's a great question. I think one of the most significant barriers is perception. And so there is a perception of inferiority. And I think this comes both with PPE, but also reusable devices in the operating room. So we have a partner in our healthcare system who does reprocessing of single-use devices, but surgeons are loath to use them. There is not a selection pressure for doing it. There's no reward for using it. There's also the complexities of industry. So we were reprocessing a very expensive single-use device prior. The selection pressure, though, came from a new polymer was added to that device by the manufacturer to try to reduce tissue sticking to the device. The reprocessing process makes that polymer disappear, and therefore now our reprocessing partner can no longer reprocess that device. If you ask the surgeons, did they notice a difference when that polymer arrived? No, they did not. There are some industry does work against us in some ways. I think often of a concept in economics called the tragedy of the commons. And this is an idea that you have common grazing ground shared by a group of farmers or herders. And if each one of them acts individually rationally to use that grazing ground as much as they possibly can, collectively, that destroys the grazing ground for all. So there are times where the individually rational decision does not lead to a collectively rational result. And I do think we see that all the time. So individually rational decisions to not use reprocessed items or to fight against your items being reprocessed can lead to an irrational result. And I think we see that all the time.
Thank you, Dr. Kenney. We'll try and save further questions for the end. Just a reminder that we would like all our panelists to read and respond in the chat, and for the sake of time. And we also encourage the entire audience to respond in the chat. Without further ado, we'll move on to our next speaker, Dr. Rosemary Kumwenda.
Thank you, Jodi, and also thanks to Daniel for making the linkages between myself and Jodi. We attended the Nordic Sustainable Health Conference a few weeks ago, and now we joined in this important webinar today. So as a startup, you can't have a presentation from the UN without SDGs. So that's my starting point, borrowing from WHO Europe, that created this illustration that we need to have health in the center of all SDGs, and supply chains definitely benefit from a number of indicators that are linked to health in SDG 12 for sustainable public procurement. My presentation, I'll talk a little bit about sustainability in the health sector, which is really nice because Jodi already described why sustainability is important in the health sector. I'll also touch on slightly about the SPHS, sustainable procurement in the health sector, who we are and what we do, and a little bit about UNDP, the resources, and finish with the challenges and opportunities thereof. I think without further ado, in terms of reiterating what Jodi said, why the health sector is important. From Healthcare Without Harm and ARUP's research conducted last year, they concluded that if the global health sector were a country, it would be the 5th largest emitter of greenhouse gases. So really that speaks volumes of what we need to do in the health sector. And Jodi has already shared statistics, so I won't go through that. And 4.6% of the global total greenhouse gas emissions is really significant, that we cannot keep quiet. So the health sector, we do procure a lot, and previous speakers have talked about PPEs and how these produce significant impact on the health of people and the health of planet. This afternoon, I attended a webinar on healthcare waste management in the context of COVID. And a lot of countries are complaining about the sheer waste that's been generated from procurement of PPEs. So that brings me to what we as a United Nations Sustainable Procurement in the Health Sector task team are all about. Being the coordinating entity, UNDP, located here in Istanbul, we coordinate a UN interagency task team on sustainable procurement in the health sector, which we established in 2012. And unlike what my colleague Daniel presented, the numbers of members is so huge. I mean, we really do need to scale up our numbers ourselves, because we have confined it initially to the United Nations. So it's 7 UN agencies that you can see on the slide, and 3 global international health financing institutions focusing on these key areas, looking at introducing sustainability in the health sector in terms of using procurement as our principal and entry point, and focusing also on the best value for money, ensuring environmental and social standards are embedded in our procurement, ensuring that we push for fairness and integrity and transparency, ensuring also adherence to international conventions, and making sure there is also fair competition, and taking into consideration the interest of UN and UN member states. So as the world is going through this COVID, which is really the greatest and biggest challenge of our time, we've seen, like previous speakers have said, how procurement sustainability criteria was really thrown out of our normal practice. There was just panic buying, and therefore very little consideration to sustainability in the health sector. While the SPHS as a team, we have said, let's focus on these key areas, which include also focusing on chemicals, ensuring that we also embed energy efficiency in our procurement supply chain, gender equality, human and labor rights, focusing on sustainable medical products. Somebody talked about packaging. It's also one of our critical areas. and resource efficiency, waste management, and water resource management as well. So most recently, the UN Planet, the One Planet initiative of UNEP invited UNDP and Healthcare Without Harm to set up a One Planet interest group under the One Planet initiative. And I think this is where a lot of us are working in the sustainability agenda for the health sector who need to converge under the leadership of UN Environment, because climate change really is a driver for SDG 12, sustainable production and consumption. And in the previous strategy of the One Planet initiative, health was not a pillar. So when a review and evaluation was done of the One Planet initiative, we pushed for health to become one of the interest groups. So it has just recently been established and is coordinated by UNDP. It serves as a mechanism to enable discussions and exchange of knowledge and practices, and to enhance greater and wider uptake of good practices on sustainable procurement between the main stakeholder organizations in the health sector. And I'm so happy that I listened to Patrick's presentation from a health worker perspective, because as a health worker myself, working in UNDP, a development agency, and we've been saying that medical practitioners, health practitioners at health facility level are not usually engaged in procurement processes. Procurement officials, on the other hand, don't get the specifications that the users require. So really your presentation was music to my ears. So the task team does share such good lessons learned from a broader UN, but also beyond the UN. And so we're in the process of recruiting many more colleagues and institutions working on sustainability in the health sector to join us under this interest group. So let me touch on a little bit about UNDP and what we do, because this is the organization I work for. So through UNDP, we have the health procurement and supply chain portfolio, which is implemented through our Global Fund health implementation support. We are principal recipient, or we've been principal recipient in a number of countries. So since 2003, UNDP has provided specialized advisory and health procurement support in a number of countries. And while UNDP serves as principal recipient, in other countries, we are just called upon to provide technical assistance support. And in some countries, we specifically just provide health procurement support. So with this portfolio as UNDP, we have used it as an entry point to ensure that we embed sustainability in the support that we provide to a number of countries. And the statistics, as you see, we have supported a number of countries, 43 countries in 2019, and 23 in health procurement with governments in 2019. So when they ask us to procure on their behalf, it means that we have to sit with the countries to ensure that we understand what capacity gaps they have, because our support comes along with capacity development. Just to dwell on a little bit more, since 2003, we have tried to quantify our support to understand the number of lives that we have saved. And I think based on our portfolio on the Global Fund, and which includes procurement of commodities for malaria, tuberculosis, and HIV, we do provide a sizable amount of resources that we get through the Global Fund portfolio of UNDP. Let me now talk about the Sustainable Health in Procurement project. This project is an idea that was mooted between UNDP and Healthcare Without Harm. And Healthcare Without Harm, as you may know, some of you that are located in the United States, they are an international NGO based in the US. And we learned our lessons and got inspiration from a small catalytic project that was funded by SCORE Foundation and the UN Foundation. And learning from a small catalytic project, we now work in 10 countries globally. So this support sustainable health in procurement project is located in 10 countries globally, including in Moldova and Ukraine in Europe, South Africa, Tanzania, Zambia in Africa, and China, India, Vietnam, in Asia, then in Latin America, when Argentina and Brazil. So I think what is interesting about this project is the mix of countries. As you know, whoever owns and has programs in China and India is really halfway through the supply chain, because these are the two countries, major suppliers of APIs, but also quite a number of health commodities are produced from raw materials that are from China, but also produced in India. And so if India and China can change their sustainability practices, they can influence their sustainability practices globally. So we hope that leveraging our support in these two countries, where the project basically uses a number of international commitments and engaging, developing with advanced economically advanced countries such as China, India, Brazil, and South Africa. We work with government systems. We also work with healthcare systems, especially leveraging the global green and healthy hospitals managed by Healthcare Without Harm. They have over a chain of 40,000 hospitals globally. This to us offers us an opportunity, because the local level hospital facility policy making and implementation of sustainability, and the idea that we can have leaders at health facility level has helped us more or less to leapfrog some of the interventions at those levels, at the decentralized level. So our project is primarily focusing on 4 major objectives. So the one is to make sure that we develop a universally adaptable criteria, because that currently is a challenge, and we don't have a universally adopted criteria and standard of sustainability in the health sector, especially vis-a-vis health procurement. And the other 2 objectives, 2 and 3, are about capacity development. So one is capacity for procurement officers. The other is capacity for manufacturers. That is why on an annual basis, we bring manufacturers globally in a forum where they exchange ideas and good practices. And this year we have next week, the forum taking place in Saudi Arabia, and hosted by the Saudi Food and Drug Administration with UNDP country office in Saudi Arabia. So the outcome, what did we envisage and what do we still envisage to see at the end of this project? We are envisaging that at the end of this project, which we are focusing on elimination of hazardous chemicals from the health sector and substituting them with less toxic substances, also focusing on greenhouse gas reductions. We are, in that regard, ensuring that we procure more renewable, procurement of renewable energies for the health sector, substituting with low carbon anesthetic agents, for example, and also looking at energy efficiency and of biomedical devices, including lighting devices at health facility level. Then in terms of reducing and conserving resources, resource conservation, we're looking at water and water management, also instituting substitutes for non-burn waste treatments, technologies, learning from the Stockholm Convention on POPs, and also eliminating harmful effluent from the manufacture of health commodities. So in the initial 3 years of implementing sustainable health in procurement project, what have we changed? Have we managed to change any of the practices at all? The answer is yes, and we're pretty happy that countries that we work with have been quite receptive to changing some of the practices. So far, 18 national and sub-national policies and strategies have been developed in China, Tanzania, Vietnam, Republic of South Africa, India, Colombia, and Indonesia, which is a spillover, and also in the Philippines, which is another spillover country. So we're extremely happy about this. 15 guidance documents we have produced, both for global actors, but also at local level in Argentina, Brazil, China, India, and South Africa. We're also looking at healthcare waste, and in the context of COVID, we have conducted a global assessment, but targeted 7 countries. And now today we were presenting the results of these 7 countries with their 7 profiles, and policy recommendations on healthcare waste management has been done. We have also identified at least more than 12, I'm well aware of that, more than 12 healthcare products and hazardous chemicals that need to be replaced. For example, single-use plastics have been identified and are being substituted with some safer alternatives, including some hand hygiene and surface instruments, laundry and cleaning, anesthetic gases and laboratory chemicals, fleet vehicle. So with all these identified hazardous chemicals and products that are in the health sector, we will be supporting countries then to identify and use safer alternatives. And lastly, we have 10 countries that have identified and are using the high impact procurement opportunities list of carbon reduction for the health sector. I think like Daniel's presentation, we also churn out a number of resources for sustainability in the health sector, including what you see, Sustainable Health in Procurement Guidance Note. This note has been translated in several languages, including Spanish, Russian, and Chinese. And we also have, identified chemicals and chemicals of hazardous chemicals in the health sector. We have also some guidance document on environmental assessment of procurement for procurement officers. So really, we do want to make sure that we can, not in 2021 when the project is coming to an end, but we know that when we are going to ask ourselves what success would look like, we would like to say that success will look like an opportune time when all of us will be reporting on sustainable procurement, which has become a norm in our practices, that would have standardized sustainable procurement language. Currently, it is not. That would have procurement criteria, which is introduced and set targets either at product level or at institutional level. We currently don't have that, and that is why we are working on this index. We also would think that we will be looking at success once the sustainable procurement language is embedded in all requests for procurement. When we have an increase in the procurement of sustainable products, when we would have created a global market for sustainable and cost-effective products. For example, our colleagues that spoke earlier talked about reusable PPEs, masks and gowns, not the single-use ones. We'll talk about success when we see that there's eco-innovation that is being driven at industry level, and that we also have a life cycle which is really the best value for money approach rather than the current one that we use. So what do I see as the challenges that we have encountered? We see the lack of standardization of sustainability. We see that there's still inadequate capacity for sustainable procurement, especially in the least developed countries. And really, if the future is going to be successful, we should stop the divisions of least developed, low-income countries and so forth. I think when a pandemic such as COVID hit all of us, it's been all of us really being affected, not just the least developed, but also the developed countries. There's also a challenge with leadership. Where we've seen positive leadership, I think speaks volumes, and we've seen where leadership in terms of responding to COVID, but also in terms of sustainability, we need leadership to ensure that the sustainability agenda is done through the leadership code, but also those who follow leaders need to know that leaders are talking about sustainability and what is translated as sustainability for the health sector. We're hoping to see that we also go over the challenge of identifying champions. And also we need to have a supply chain. The other challenge would be a supply chain which is extremely complex. I think previous speaker talked about the complexity of the supply chain, but it's not just for the health sector, it's the entire supply chain of commodities is extremely complex.
Thank you so much, Dr. Kumwenda, with gratitude.
It was the last slide, and I was wrapping up that we do have opportunities, and I think they've been highlighted by the previous speakers. Sustainable development goals offer us the opportunity to do more in sustainability. Let's create a movement, and thank you so much for inviting me.
Unfortunately, no time for questions now, but we can take them in the chat. I know Dr. Kumwenda is advanced in her time zone and needs to wrap up shortly. So I encourage the audience to ask questions to her in the chat, and we can certainly make sure we can reach out to her additionally afterwards for those who would like to continue the conversation. We'll now move on to our next speaker, Mr. Adam Robinson.
So first of all, Dr. Sherman, to the folks at the Nordic Center, I really appreciate the opportunity to speak to this group. You know, my perspective really is as a supplier. Is Dr. Sherman mentioned at the top, a former chairperson of our trade association for the reprocessing industry, which is known as the Association of Medical Device Reprocessors. And I was also the former commercial director for Cardinal Health's reprocessing division called Sustainable Technologies. And so, you know, a lot of the questions that came up, you know, a lot of the things that Dr. Kenney talked about, you know, I hope to provide a perspective on from the lens of the supplier community. So first of all, at the top, from a nomenclature perspective, just bear with me through this. Reuse is a general term. When speaking to single-use medical devices in the US, the regulatory pathway, FDA views cleaning a device, marketing and selling that device back to an end customer as reprocessing. Outside of the US, it's globally known as remanufacturing. For the purposes of my presentation, I'm mostly going to be using the word reprocess. Okay, so device reprocessing defined. So this is the single-use product value chain, and I hope can everyone see my cursor?
Yes.
So the single-use product value chain. So we've used both the term value chain and supply chain. When I speak to value chain, what I'm really considering is everything that it takes to make that end product, as well as get that end product to the clinician for use. And so, you know, oftentimes we use supply chain, and that's really getting the finished product to the clinician or hospital for use. To take that a step back, a lot of the challenges that we've had in light of COVID is sourcing of raw material, as Ben spoke to. So it's not only where you're manufacturing the product, but the raw material inputs to this process that became problematic at the height of COVID. So usually what would happen in a global manufacturing medical device company, you would source raw material, You try to do that as close to your manufacturing site as you could. Often you would manufacture in one global location where either there's tax incentives for you to manufacture there, it might be a free trade zone, or the labor cost is low, or it could be an area where there's expertise, a knowledge cluster on how to make that particular widget that the manufacturer is making. From there, there's a batch, lot, test, and spec process after that device is made. I think the number is in the US, at least roughly 60% of the single-use devices then go to sterilization. From there, they will go through a distributor, a Cardinal Health, a Medline, and Owens & Minor in the US, and then go into clinical use and finally over to disposal. So it's a one-way journey where the product is, as an asset, belongs to the manufacturer until the point that it hits the distributor. And from there, the asset exchanges hands twice, first to the distributor, then to the hospital who owns it and then disposes of it. The difference with reprocessing, there we go. The difference with reprocessing is that the device as the asset goes back to the manufacturer. And so a simple way to think about it is hospitals are our biggest supplier in the reprocessing world. They're also our least predictable, most chaotic, probably in some respects unresponsive suppliers, but they're the largest suppliers to medical device reprocessors. And what this creates is a set of aligned incentives, as Dr. Kenney was speaking to, where the value that we create through this process benefits not only the reprocessor in the form of low cost raw material, but also benefits the hospital in the form of a lower acquisition price. Now, to give you an idea of the size of this, the medical device world operates at scale. And to give you a sense, in 2018, all of the reprocessors that belong to AMDR submitted our collective data. And what we found is that the total dollars saved was $472 million. It's the difference between the acquisition price for the reprocessed device and the device that hospital would have otherwise purchased new. That's an annual figure. There was over 15 million pounds of medical waste kept from landfills. At Cardinal, over this time period, we actually, to give you a sense of number of devices, we had reprocessed over 10 million single-use medical devices. There's over 7,000 hospital surgery centers in US and Canada that reprocess. And in Europe, largely EMEA, there's over 1,400 hospitals that participate in commercial reprocessing. They may do one device, they may do an assortment of devices, but to give you a sense of the size of the industry, it operates at scale. From a quantity perspective, and it's global in nature. So a little bit of the headwinds that we experienced as a manufacturer, again, as Ben mentioned, there were some challenges from an input standpoint. As a reprocessor, our input being hospitals created some obvious headwinds. The first is declining elective procedures meant that there was reduced demand for overall medical devices. That cascaded through our value chain and meant that we were getting less products to reprocess and turn around to hospitals. We also, for a period of time, experienced access restrictions. Access restrictions occurred in a variety of ways. Number one, getting the PPE to our device technicians to go into a hospital to collect the device to return it. There were some hospitals that were on full-on lockdown. that wouldn't let us in. And, there was a period of chaos in March where, sometimes hospitals didn't know what their policies were. And so that invariably created further constraint on the amount of devices that we could collect and turn around. Secondly, in our manufacturing plants, we experienced a series of headwinds. We did not know what the protocol was for how long COVID would stay on a device. And so we needed PPE to be able to sort devices, to qualify them, to turn them around, basically to operate our plants. So we had to come up with a variety of policies and procedures, use the best science we could. We are in many respects in a similar position that hospitals were in terms of keeping their doors open. And then finally, through that entire value chain, the net result was that we were turning around less devices, and the devices that we had that were available were in less demand. And so, we were going to hospitals and offering up devices that the hospitals didn't need. And so, as you might imagine, the question that came back, is Dr. Kenney mentioned quite often, is, that's great that you have this reprocessed device, but we could really use some help on N95s. Or what are you doing with PAPRs? Or what are you doing with isolation gowns? Can't you do something about this? And so the answer is yes. We got to work pretty quickly assessing our ability to be able to reprocess devices. And from a fundamental standpoint and capability standpoint, everything that we do through our validated processes could apply to PPE. However, the timeline to get FDA to 510K, to basically to approve us to commercially market and sell those products in a traditional sense, is quite lengthy. Fortunately, FDA has a pathway, an accelerated pathway called emergency use authorization that applies to medical device manufacturers. And fundamentally, there's two components to it. The first is that during a health emergency, the FDA can authorize an emergency use authorization for the use of unapproved medical products or unapproved uses of medical products, where essentially there's a pandemic situation. This is the arrow in the quiver that FDA has to get products to market faster than they normally would. However, to enact an EUA, the Secretary of Health and Human Services must make a declaration of emergency. And so at the onset of COVID in the February timeframe, as a manufacturer, we knew that there was an issue. We knew we could solve it. However, the regulatory pathway that we had was going to take us months. And when FDA came back and declared a pandemic emergency in late February, that gave us the pathway to be able to assess what we would do, how we would respond, and how we would engage FDA in an accelerated fashion. Shortly after the pandemic was declared, FDA actually gave us guidance, all manufacturers, on how to submit for emergency use authorization for decontamination of FFRs, commonly known as N95. The first organization to receive an EUA was Battelle, full name Battelle Memorial Institute. And Battelle really set the tone for a lot of the manufacturers, including the reprocessors, that were evaluating their approach to the pandemic. And the reason is that Battelle had received some funding from FDA in 2014. And at that point, FDA said, and HHS, Health and Human Services, said to Battelle, hey, we've gone through swine flu, we've gone through SARS, there's going to be another epidemic. Can you evaluate the ability to decontaminate PPE should another pandemic hit. And so it took them 3 years, but they developed a system at low scale using off-the-shelf technology, and took that study and basically applied it to their emergency use authorization, which they received. The sterilant that they used was what they call vapor phased hydrogen peroxide, but basically is vaporized hydrogen peroxide. Shortly thereafter, Steris received an EUA for using the same sterilant. Shortly thereafter, J&J, division of J&J called Advanced Sterilization Products, received emergency use authorization for hydrogen peroxide gasified plasma. So basically, again, hydrogen peroxide. Stryker received an EUA. A company called Sterilucent received an EUA. All of these EUAs were using the same sterilant, which was vaporized hydrogen peroxide. Come late May, Steris on their AMSCO steam sterilizers received an EUA. So this was the first emergency use authorization that we saw for a sterilant that was not vaporized hydrogen peroxide or some derivative. Stryker and Steris formed a relationship using Stryker's reprocessing network to sterilize N95s. I'll click through this. You get the sense that after FDA determined the pathway, that's what really accelerated our ability to respond to the pandemic with a validated, commercially validated and scalable solution. However, when you go back and look at the trends, you find 3 things. The first is there were commercially validated decontamination processes which occurred outside hospitals. So in other words, a commercial solution that could be done at scale and didn't require any hospital resources, be it labor or space. The second was commercially validated decontamination methods using existing sterilizers. So, take the ASP example. A lot of hospitals in the US and around the world have ASP sterilizers. Those sterilizers could be used to decontaminate N95s. And then the third is we actually saw some hospital systems, as you saw, Duke received an EUA, as well as Michigan State received an EUA. There's a variety of different solutions that individual hospital systems, such as Yale, that Dr. Kenney spoke to. There's a variety of different solutions that hospitals did on their own as well. And so to add some color to this, you can see some trends here. And that's that, first of all, 75%, so 3/4 of the EUAs relied on use of hospital resources, be it an existing sterilizer that hospital already had, or space for the vendor to come in and set up their sterilization system. Second is the cycle times there was cycle times and or quantity restrictions. And so there's only, steam sterilizers are quite a bit larger, but in a lot of the VHP low temperature sterilizers, they're space constrained. And so you can only put so many N95s through those sterilizers. And then you end up with other issues. You need biological indicators. You need packaging to put those N95 masks in, and you need to ensure that you're following the protocol so that if there is an issue, you can report on any issues that come up with FDA. And all of that created barriers to starting up a lot of these EUAs. Now that said, what this did prompt is manufacturers, suppliers to begin looking at sterilization of PPE at scale. And so one of the things, at Cardinal and really across the reprocessing industry is we started looking at new product applications, devices that we had not typically ever considered reprocessing, became items that customers were asking us for. Ventilator disposables, PAPRs, isolation gowns, N95 respirators. All of these product categories were items that have high velocity. They're used a lot in hospitals, but we as an industry had never looked at because of the cost. And then the other thing that I think is really moving the reprocessing industry forward is looking at different disinfection or sterilization methods that can be done at scale. So Dr. Kenney mentioned ETO. That's what a lot of reprocessors use for high-level disinfection or terminal sterilization. However, we also considered looking at UVGI, so ultraviolet light, as well as vaporized hydrogen peroxide. And the latter can be done at scale. It's cleaner and enables us to quickly turn around products. It's a little bit more gentle on products than on medical devices than UVGI.
I'm so sorry. We need to leave time for the remaining speakers. So final thoughts?
Right at the last slide.
Sorry. Well, thank you very much. For time's sake, we'll take the remainder questions via the chat only. And again, encourage all our panelists and all our attendees to communicate via chat. And we'll now move on to Andreas. Thank you very much.
Okay, thank you. I will add some on about a way to reduce the carbon impact of the provider of healthcare. In this case, we have Sweden as an example on Swedish healthcare and what is done to reduce emissions, and especially how to include the scope 3 emissions. And just for the ABC, as you might know, scope 3, of course, we're talking about the indirect emissions, upstream and downstream from production and transport and disposal, as opposed to the more direct emissions of the organization itself. And this can be done through life cycle assessments. That's the LCA I'm talking about. How to quantify the impact along this path. And so the setting for doing this in Sweden, we have a decentralized healthcare system with the 21 regions responsible for the healthcare. We do not have a centralized system as the NHS, which could make things easier in how to follow things up, but we do it sort of more bottom up. And since some 10 years, we're doing this with a number of indicators, and recently we're starting to do the climate disclosure reporting also as well for the regions through this yearly report. The easy numbers have been previously to follow sort of the energy use per square meters. We've been seeing that going down 14% in 11 years. The renewable fuels in public transport, which is also a responsibility of the regions, going up to 91% renewable fuels, electricity, biogas, etc. And the emissions from medical gases, from anesthetic gases, going down to less than half. The share of organic food, etc. Waste, on the waste side, we have increased recycling rate, but the waste itself is also increasing. And this we do in sort of open comparisons between the 21 regions, so we can do some benchmarking. And we also sort of lift the good examples and the good practices to see what can be done. And since some 10 years, there's also a cooperation on sustainable procurement. So it was very delightful for me to hear from Dr. Kumwenda about the UNDP program also on this part. Since a couple of years, it's also working on the environmental side of products with on priority risk areas. It is mainly so far on chemicals, but it's slowly moving on to including carbon dioxide emissions too. And then we have sort of bottom up followed the climate reporting of all the 21 regions. And this is done in very various ways in areas such as energy, cooling agents, anesthetic gases, waste food, building materials, single-use materials, laundry, public transport, etc., commuting. And the easy gains, we can see going down like 50–60%. But also we have the tough sides is the scope 3, the indirect emissions. And there the regions are relying on consultants on how to follow this up. And from the bottom up, we only sum up to about 1.5 million tons of carbon dioxide equivalents. But when we do this on a top-down basis instead, from the National Procurement Agency, we see a sum of 6 million tons of carbon dioxide equivalents. So we're a country of 10 million inhabitants, so that's about 600 kilos per inhabitant from regions, and maybe around half of that is healthcare, or a bit more than half, I would say. And one of these areas is also the where do you place your money, the pension funds for the doctors and the nurses, and what carbon is related to that. And my final slide is sort of going in a little deeper on this spend analysis, which is our sort of big hope of how to be able to follow this more continually in procurement. And our hope is to include these kind of analysis and data into the purchasing analysis systems that are on the market. And right now it's done sort of both on an input-output methodology with the statistics on national industries through Exiobase, and it's also done on through a process of sort of looking on the individual products that you're buying through the procurement vocabulary that is common in the EU, and on selected products. So we can't cover all the products, but selected products in energy, transport, construction, food, ITC, paper, chemical products, and etc., and medicines. And this is done by the Swedish Environmental Research Institute, and they're relying, of course, on, as far as possible, on environmental product declarations, for which there is an ISO standard. And so far, we've come the longest way in construction materials and food. And I think that's because these are of interest for many sectors in society, as you know. And the National Road Administration is quite advanced in placing these kind of carbon emission reduction requirements for major construction projects to reduce carbon impact of something like 30%. And a lot of construction is also done in hospitals and around hospitals. So it's of big relevance for us as well. And food is also something that is of high interest also for citizens, and with a good availability of LCA data. So I hope that Dr. Kumwenda will be successful in her environmental program project. So there will be more availability and more common language, so we can place these demands in procurement as a way to reduce our climate impact substantially. Thank you.
Andreas, thank you so much for such a great talk. We're really excited by all the work that's coming out of Sweden and the Nordic states and your wealth of information. I'm going to encourage people to continue to ask questions via the chat. For time's sake, we'll move along to our last speaker, Ornella. If you can call up your slides, Dr. Benedettini.
Thank you, Jodi. In business and industry, the trend toward servitization refers to OEMs that move from an exclusive focus on producing and delivering products to a goal of providing total offers, including products, as well as a range of product complementary services. For example, financing, maintenance, repair, but also upgrading, take-back, refurbishing. In servitization, products and services are designed and combined so that they are jointly capable of fulfilling customer needs. The value proposition is centered on the needs that the customers seek to address using a specific product and not on the product itself. In practice, servitization is a vertical integration that changes the division of labor in a value chain, with the OEM taking on activities that were previously performed by the customer itself or by third-party service providers. This is an attractive opportunity for both manufacturers and customers. For OEMs, services provide a recurring revenue stream with usually higher margins than product sales. Services can be a way to differentiate the total offering and to establish a long-term relationship with customers. For customers, servitized offerings reduce the need to invest in service assets, and as we will see in some situations, also in product assets, and allow to get rid of service responsibilities without at the same time increasing the number of suppliers to deal with, because basically the product manufacturer provide both the product and the complementary services. With this servitization, these opportunities are pursued through a business model transformation. That is a change in the way, especially the manufacturer does business, delivers value to customers, and the way it is actually compensated for the value that it creates. This business model transformation involves a different way of thinking about products and a different way of managing the products during the life cycle. And this is a significant potential to facilitate, to enable profound changes in key areas, including like product take-back, product and service design, resource efficiency, and also supplier-customer interaction. Research and practice identify three main types of servitization: product-oriented servitization, use-oriented servitization, and result-oriented servitization. With product-oriented servitization, the focus of the business model and of the economic transaction between OEM and customer is still the sale of the physical product, but some additional services are added. For example, repair, maintenance, upgrading, take-back. In the medical sector, this may be, for example, the case of a provider of reusable medical gowns that also offers, washing services. The customer purchases the product and is charged for the services separately. With use-oriented servitization instead, the focus of the business model is no longer the sale of the product, but the sale of product use. This may also include services to assist the use of the product. For example, this can be the case of, again, let's say a provider of reusable medical gowns that retains the ownership of the gowns, supplies the gowns, collects them after use, washes them, and redelivers them after use. The customer may be charged every time they use a gown or for having the gown available for a given time. As a further example, for example, Medtronic, GE Care, but for sure many other producers of medical equipment offer consumption-based arrangements for their advanced diagnostic systems. Customer payments are based on the number of procedures or tests conducted with the equipment. So the manufacturer takes care of everything related to the equipment. Finally, with result-oriented servitization, the focus of the business model is the sale of a specific result or performance, which is achieved through a combination of products and services. This form of servitization is similar to an outsourcing arrangement in which the customer outsources the activities performed by the product. The manufacturer retains the ownership of the product, but also chooses the product to use to achieve the agreed upon result. This may be the case of a manufacturer of power units that guarantees a specific room temperature in an area of like a hospital. So the manufacturer is free to choose the kind of equipment to use, to choose the design of the system, and basically decides how to operate and maintain it. Use-oriented and result-oriented servitization are certainly more advanced than product-oriented servitization. The key element, and probably the main benefit for the customer, is that utility is provided through the sale of service units without the need for the customer to purchase the product. However, while in use-oriented servitization, the customer can choose the product and can choose the way the product will be used, in result-oriented servitization, this is not a viable option because actually it's up to the manufacturer to choose and operate the product. Therefore, use-oriented servitization is the most advanced form of servitization, which is actually applicable in most of real-scale situations. As further examples in, different industrial sectors, Rolls-Royce Aero Engines, for example, provides jet engines and charges its customers per hour of flight. Or Xerox charges its customer per paper copy, or Philips charges customer for amount of light provided, number of looks, or Michelin, the tire manufacturers, charges the customer for miles driven. So the OEM owns the equipment, maintains it, and retires it when it's time to upgrade it. These different types of servitization differ also in their environmental potential. Product-oriented servitization certainly provides an incentive to keep the product in good working condition if, of course, the OEM takes over maintenance activities on a contract basis. It also provides some end-of-life benefits because OEMs may see take-back schemes as additional services to offer to customers. Use-oriented and result-oriented servitization provide instead greater incentives to prolong the life of products through maintenance and upgrading, and actually to manufacture products using longer life material, because clearly the OEM retains the product ownership, so it has an interest in this. Again, for the same reason, use-oriented and result-oriented servitization provide additional incentives to reuse product and product components, and include also end-of-life strategies in the design of, in the development of new products. In addition, use-oriented and result-oriented servitization incentivize using products as intensively as possible, and also encourage a more flexible use, flexible and selective use of products, because in actual fact, given that the customer doesn't buy the product, he can get actually the product that is most appropriate for the task on hand. Finally, use-oriented servitization, result-oriented servitization allows more radical innovation and the search for novel and perhaps even more sustainable ways to fulfill customer needs, because of course the OEM has greater flexibility in developing the solution to customer problems. In addition to these environmental benefits, servitized offering can actually be useful in a number of critical situations. These are a couple of pictures that Jodi Sherman recently shared with me. And actually they refer to the shortage of PPE medical gowns during the COVID pandemic. Actually, servitization could have helped avoid a similar situation, because might have encouraged hospitals to use reusable gowns, because the OEM would have provided also, I don't know, the washing, the hygienizing services. But even more, with use-oriented servitization, hospitals would have avoided also the initial investment of purchasing the gowns, because the manufacturer would have provided them and the hospital would have paid just for each single use. So servitization in this situation would have given, I mean, flexibility and would have allowed the adoption of reusable devices, which of course would have had. Different types of servitization actually have different environmental and economic value, but actually overall they can actually combine economic value with environmental value. But this is actually not free of challenges. The more advanced the servitization business model, the greater also the challenges that the stakeholders have to be deal with. I personally see challenges in 5 key areas: value proposition, transformation, product service design, implementation, investment, and risk. As I said, these are risks for both the customer and the OEM. So very briefly, without going through the full list, some key points. Regarding value proposition, the customers do not always have sufficient knowledge about the cost of the product during the life cycle to assess whether the service contracts, and especially ownerless-based solution, actually lead to cost savings for them. Another problem, which another speaker has already mentioned today, is that there are not sufficient regulations and guidelines that help customers assess the quality of the reprocessed equipment. The obvious consequence is that customers and the public opinion as well tend not to trust such equipment. And this is clearly a main limitation in the adoption of certain types of servitization. As regards the OEM, in terms of value proposition, they may struggle to communicate the value of the offering to the customers, but to the market as well. Because, for example, the market may see this servitization as a lack of focus, and manufacturers may struggle to get support from their investments. In terms of transformation, OEMs certainly have to deal with the fact that reconfiguring responsibility and changing the relationship with the customer changes also their income and profit equations. In particularly, product revenues go down and are replaced by service revenues, which are smaller, but they are more continuous. OEMs also have to adapt their corporate culture to the fact that products are no longer the only center of their business. Sometimes products have to be downsized to simple platforms for the delivery of the service. Customers, on their end, have to accept the involvement of the manufacturer in their day-by-day activity. Sorry, clearly, the servitization business model offers attractive opportunities to both manufacturers and customers. When the more advanced servitization is adopted, so like use-oriented or result-oriented, the business model turns incentives for product durability and upgradability upside down. So the incentive moves from volume, producing and selling product, to product performance. The greater economic and environmental value of servitization exists for both the manufacturer and the customers, but there are challenges. In particular, for the challenges, there's the potential higher cost of ownerless-based consumption, the risk that manufacturers focus less on product innovation because they really focus on the service business, and there's also a contract that states the responsibilities and decision rights of the two parties. And this is not easy to deal with. So that's all. Thank you.
Thank you so much to Dr. Benedettini and to all of our guest speakers. My apologies for a couple minutes after the hour. Obviously, this is a large topic, and in the future, we'll have to give more time to this because it's really important. So thank you once again to everyone, and especially to Daniel Eriksson and all our support staff from the Nordic Center for Sustainable Healthcare, and also from the Yale Center for Climate Change and Health. And we will post the materials on our websites for posterity purposes. Thank you again.
Thank you.
Thank you.
Thank you.
Thank you.
Thanks a lot. Learned a lot.
Indeed. Bye. Bye-bye.
Thank you.